Pepper Older Americans Independent Centers, or Pepper Centers. The Aging Initiative is led by Dr. Jerry Gerwitz at the University of Massachusetts and Myers Primary Care Institute, along with co-PIs Elise Adams and Jay Magaziner. My name is Heather Whitson. I'm an associate professor of medicine and ophthalmology and the director of the Duke Aging Center, and I co-lead the Aging Initiative Dissemination Workgroup, along with my co-leader, Leah Hanson at HealthPartners. Before we get started, I need to cover a few technical details. Due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. So unless you're logged in as a host or panelist, your line is muted. However, we welcome and encourage audience participation using the Q&A or chat features of the webinar software. If you're in your Cisco webinar portal, look at the row of circles across the bottom of the screen and click on the chat bubble icon until it's highlighted blue. If you have questions for our speakers, please click on the Q&A tab on the right side of the screen and type in the Q&A box. Leah and I will be keeping an eye out for those questions under the Q&A icon. As time permits, we'll read questions for our speakers after the presentation. If you have technical or logistical questions, we ask that you submit those in the chat box, which is above the Q&A box. Please make sure that you're identified by either your name or your participant ID, so that our webinar hosts will be able to help troubleshoot any problems that you're having with audio or other issues. With the chat function, you can choose whether you would like your comment to be visible to all participants or only to the hosts. We want to extend a huge thanks to Catherine Anzoni and Chris DeLude at the Myers Primary Care Institute. They do amazing work behind the scenes to make this webinar series possible. Catherine will be monitoring the chat functions today and will help with any technical troubleshooting. Now I'd like to introduce today's speaker. Dr. Sherry Ling currently serves as the Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services, or CMS. She assists the CMS Chief Medical Officer in the agency's pursuit of the CMS mission of putting patients first. Dr. Ling's committed focus is on the achievement of meaningful health outcomes for beneficiaries and families through the delivery of high-quality, person-centered care across all settings. Dr. Ling contributes her clinical expertise as a geriatrician and rheumatologist and her program expertise as the DCMO to the development and implementation of the CMS roadmap to address the opioid crisis. Dr. Ling leads the Clinical Services Federal Work Group for the National CMS and additional stress resistance to bacteria, and also contributed to the Cancer Moonshot Initiative under the previous administration. Her clinical focus and scientific interest is in the care of persons with dementia, multiple chronic conditions, and functional limitations. We will also be joined by two discussants on today's webinar. Dr. Nathan Boucher of Duke University is one of the current Aging Initiative MCC scholars, and Barbara Kiewicz of Stanford Healthcare and Sutter Health is a representative from the Aging Initiative Patient Caregiver Advisory Panel. With that, I am going to turn it over to our speaker, Dr. Lee.
Hi, good day. Are you able to hear me all right? Just doing a sound check.
Yes,
all right.
You sound good.
Wonderful. Thank you, and thank you for the honor of being with you all today. And I, as a geriatrician, as clinician, as was mentioned, and as one who is helping to support CMS in a variety of very mission-focused initiatives, I really welcome the opportunity to speak to those of you who are both generating the evidence that we build our policies on, but also those who are providing care to our beneficiaries. So really, thank you, and I'll try to keep my comments brief. But if I could have the next slide, please. So I must say that this is my official federal disclaimer, that what you hear today are my opinions. and really that, for any policies or programs that are mentioned, things change very quickly, and all official policies are posted on the CMS webpage, and it's always good to check what the latest is, because things change very quickly. As we are learning, so does the evidence. So I have no conflicts to disclose. Next slide, please. So just as a reminder, so CMS, our role is that of a payer, but we are part of the Department of Health and Human Services. And so we have been using our role as a payer to help drive the healthcare delivery services and system in the direction that really delivers to higher value, accessibility of healthcare services equitably, and to ensure that the quality of those services is actually also equitable, and yet that the care that's provided, those services are also affordable. And all this is also available for public consumption, and that we believe our stakeholders, our beneficiaries, your patients, your subjects, your research subjects, really can utilize information in the public domain to really understand the care and services that they receive, what they mean, what the trade-offs are, and also that all of this information can speak to what are the needs that the treatments and services are meant to deliver to. And we support innovation in being clear about what the services are meant to do, which is to improve health outcomes for those who we serve. So we're part of the HHS initiative, but our role is primarily that of a payer, and optimally to be able to pay for value and to drive improvement that delivers higher value care. So next slide, please. So we have an enormous number of beneficiaries who are coming online each day, and our health system needs to be prepared to be able to provide care and services to our beneficiaries. And again, care that is of high value is of incredible importance to us. The challenge is, how do we define a value, and how do we, in an efficient and evidence-based way, put forward, refine, implement, and refine again those policies, and keep abreast of the evidence as it emerges. And that pace is sometimes quite challenging, particularly as innovative approaches come online. We also need to know whether they're safe as well as effective, and if they're useful. So next slide, please. So our role as a payer, we touch upon approximately 1 in 3 Americans across this country, and that stands not only, this is an aging population, so aging as it applies throughout the lifespan, although, in Medicare, our beneficiaries are defined by age. It's a benefit category requirement by age, disability status, and in Medicaid, disability, and also financial criteria, and those who are dually eligible, who meet criteria for both benefit categories, Medicare and Medicaid. And we also recognize that a growing proportion of our beneficiaries are actually tri-eligible, so also our veterans, and we thank them for their service. Next slide, please. So one of the challenges that we have, and this slide keeps, every time I update this is a snapshot based on claims data, a cross-sectional look on the fee-for-service beneficiaries. Each time I update this, the slide becomes more and more purple. And what is purple depicted on the slide is the proportion of beneficiaries that have 5 or more other conditions, in addition to the target condition that appears on the y-axis here. So as you can see, if we focus on heart failure as an example, about 2% of the population has just heart failure. And more than 60%, probably 65%, actually have 5 or more conditions in addition to heart failure. So this is a snapshot of the complexity of our beneficiary population, the prevalence of multimorbidity, and as you all know, these have not only independent but potentially synergistic effects on outcomes. And so therefore, we are extremely interested in what are some of the outcomes that are meaningful for our programs and policies, and therefore the evidence and science that you all put forward. What are those outcomes that might be relevant and important to the people who we serve who have not only one condition, but multiple conditions? So I really appreciate having the opportunity to address you today. Next slide, please. So with our CMS strategy, we focus on improving our health outcomes for our beneficiaries, but we also have 4 strategies, including really being able to empower our patients or beneficiaries together with their clinicians to make decisions about the healthcare. And again, having the evidence and information at their fingertips is really an important part of some of our efforts. We also have been ushering in state flexibilities and local leadership, recognizing that there's incredible variability across the country, not only about the type of conditions and the complexity of the populations, but also the care and services that are available. And because we're a payer, we also support efforts which speak to affordability. And as part of our efforts, really, again, as I previously mentioned, desire equity and accessibility to care and services that actually meaningfully improve health outcomes for our beneficiaries across the age spectrum, and of course, improving customer service. And that is the opinions of our beneficiaries and also the clinicians who and health systems and providers who we rely upon to provide the care and services that the CMS as a payer pays for. Next slide, please. So we have, in addition to our strategies, we have strategic priorities, and for 2020, you can see how these 16 different priorities are quite a variety, including, as I mentioned, information, so price transparency, being able to effectively fight the opioid crisis, and yet still meet the needs of people who have chronic pain as part of that, not only being transparent about prices, but also lowering drug prices, fostering innovation, and all along the outer wheel, key areas of work, including ensuring safety and quality, empowering our beneficiaries with information, and really helping to transform our various programs and policies in a very strategic and evidence-based way. Next slide, please. So when we talk about the evidence and using evidence, translating it into policy, CMS programs and policies come by way of specific authorities that are granted to CMS. So as an example, those of you who are familiar with some of our innovation work, our Innovation Center has a specific authority to test new care and payment models. And likewise, through our Center for Medicaid and CHIP Services, and also the Innovation Center, we have authority to test by way of demonstrations and projects and waivers, as well as accelerate innovation. But that is a specific authority. We also have authority to set the minimum care and safety standards for all healthcare facilities that participate in Medicare, that is, get paid by Medicare, and to enforce those expectations across the care continuum, from acute care hospitals to nursing homes, but we don't have conditions of coverage or participation for physicians or clinicians. We do, however, also have payment authorities that are separated by setting. So physicians are paid differently than healthcare providers or facilities, and these rules are published, and all of the expectations and requirements are published at different frequencies depending on the rules. Our payment rules are updated pretty much on an annual basis, and that is all subject to notice and comment, public comment, and what we call rulemaking. So it is the way that we invite the public to view our opinions or suggestions or proposals, and with those public comments that are received, we can then finalize with logical outgrowth from what comes in through public comment to a finalized proposal from proposed to finalized rules. We also have authority to provide technical assistance or quality improvement, and also through the different benefit categories, provide payments not just by setting, but so Part A, hospital and skilled nursing facility services, as an example, home health services, Part B for the drug benefit. So these are all authorities, and as we use the evidence, these are the program and policy levers we look to and ask ourselves, so what is the evidence that we need to know that actually we can utilize and build our policies and refine our policies based on the evidence that you all provide. Next slide, please. So importantly, this is a rather dated slide, but conveys an important concept. So when we think of care and services, if we take the right pillar first, and we are looking at new treatment modalities, the question to us is there sufficient evidence that using a new treatment or intervention compared to the alternatives actually meaningfully and clinically improves health outcomes for our beneficiaries. On the left side of the slide is those that category for diagnostics. So the rule of thumb we have is that the evidence provides incremental information, it's strong support that the diagnostic test provides incremental information that then can be used in the care and management of the patient. That is, that we can see a change in clinical management or the recommendations thereof, or at least considered in the management of the patients, which that management then translates into improved health outcomes. Now, I will say that one of the gaps that we see time and time again is that the evidence that's provided either for therapeutics or diagnostics actually doesn't include the beneficiary population that we have authority to cover treatment and services for, that is the Medicare population. And it is understandable given that the bar that is really targeted for by many therapeutic developers is for safety and efficacy, but for CMS, we actually also have to consider utility. So clinical utility in the population in which it is meant to be used. So for older adult patients, we would prefer and at times require that the evidence is directly applicable to the Medicare beneficiary population if it is intended to be used and covered or paid for by Medicare. Next slide, please. So this is the construct of evidence sufficiency But in addition, the way that coverage determinations are made are either by under local contractor discretion. The Medicare administrative contractors actually pay for the claims on behalf of Medicare, on behalf of CMS, or by way of national coverage determinations, where the evidence is deliberated in a public forum according to a statutory time frame and also to meet statutory requirements. Next slide, please. Oh, and at the bottom, evidence gaps remain in older adult populations. So older adults are needed in clinical trials. So bottom line for that slide. Next slide, please. So I mentioned payment, and you know, there are many services that Medicare pays for, Medicaid pays for, that actually are utilized in the care and keeping of older adults. This slide says that some services that can be provided to people with serious illness, but this also applies to the beneficiary population at large. And you can see that it is quite an array that spans that which might be delivered during physician services or outpatient care, and also for serious illness, end of life, hospice, and everything in between. So these are payments that are made as fee for service or for each instance. And as you recall, we really are trying to, in addition to pay for individual services, think about how do these support improvement in outcomes, or at least stabilization in outcomes, or how do we put this together on the same page as quality, so quality care that achieves you know, better outcomes for a given payment level is a value construct that we've been working on and working hard to implement. Next slide, please. So as we move to value, next slide, please. We have been evolving from, you know, category one, where it's completely fee for service, to a second category, fee for service, which has some link to quality and value, to category three, which is where a large portion of care is delivered through and paid for right now, which is alternative payment models, but still somehow built on or tied into a fee for service architecture. And the fourth category, which is about population-based payment. And so this has been the hardest category to try to crest into because of the, it requires data infrastructure and a aggregate, a measurement of who is in the denominator of the population-based payment. So that has been a bit challenging, but is work in progress. Next slide, please. So one of the programs that we have authority to implement is the quality payment program. On the right side is alternative payment models, as I've mentioned, which could be accountable care organizations which link together care and services over space and time, and alternative payment models which might knit together a episode that is across acute hospitals to post-acute care, or individual bundles, if you will, of the care and services for individual conditions over time and space. On the left is the merit-based incentive program, which is it builds on quality, whereby clinicians can select what quality measures they participate in, but also receive credit for clinical practice improvement alternatives, activities, use of electronic health records, and also cost. Now, on the right, on the alternative payment models, you notice the word advanced. And advanced means that there is some financial risk that is on the table, whereby the practices stand to gain money if, you know, gain a bonus if money is saved with preservation of quality, which would be optimal, or that they would not be able to gain that bonus payment if either quality sinks or where costs exceed what the average or the expected might be. And there are various constructs of this that are evolving through the Innovation Center and also external to the Innovation Center work. So that world is really evolving quickly. Next slide, please. So we have been working on MIPS value pathways, which create a participation framework where specialty societies and a variety of clinician types can actually help to co-design what quality looks like in a way that fits the practice modality, but also, importantly, the patient care population, the population of patients that are the practice is responsible for, and it's intended really to help to streamline the merit-based incentive program reporting by limiting the number of quality measures that one would need to report to. So really a consolidation of quality into a smaller but a more robust set of measures. Next slide, please. And this is really the framework that we have been moving in the direction towards, which is that there is a foundation of interoperability and also where clinical practice improvement opportunities are kind of part of the mix, as is cost and quality, built on the foundational infrastructure of electronic capabilities. Next slide, please. So just as an example, we have quality measures, and you are studying aging, and one of the aging related conditions is dementia, and we've looked at a suite of dementia care measures, and unfortunately they apply to a population where dementia is already diagnosed. We desperately need quality measures that really have acceptable test characteristics that enhance the ability to detect cognitive problems earlier. So part of the program is to be able to bring online new measures and evidence that these measures are not only meeting test characteristics as you would for any type of test, but also that they are useful in the care and keeping in specific care settings or across care settings. So we need that type of evidence. And despite the increasing prevalence of cognitive impairment and the many manifestations over the care settings that we see, we just have had difficulty receiving that type of evidence into our pipeline. So appealing to you, those of you who do this type of work, we need you. Your country needs you. So next slide, please. So, you know, our Meaningful Measures initiative really tries to further focus the world of quality measures on that really which is meaningful across different types of specific conditions. There may always be a need for condition-specific measurement, but looking at the Medicare population, we know that it shouldn't be a trade-off between diabetes and kidney disease and how you measure and provide quality in either or. If we think about the people who have these conditions, we have to be able to provide high quality care to people who have those two conditions and more, as exemplified by one of my initial slides. Next slide, please. So this is intended to measure what matters, and this includes, the domains of focus include effective coordination of care, effective treatment and prevention of chronic disease, integration and use of community best practices, making care affordable, strengthening person and family engagement in their care across the care continuum and across the lifespan, and also enhancing safety of care, reducing harm that results from as a consequence of the care itself. Next slide, please. So there are some notable gaps, including one of our priority areas, which is the appropriate use of medications, treatments, You can replace the word opioids with other potential therapeutics to effectively manage pain and manage pain safely, avoid harm. We would welcome the addition of new nursing home safety measures, interoperability and care transition measures that go beyond our administrative means of knowing when people are admitted, readmitted, perhaps, some of the measures of avoidable such events, the appropriate use of care and services, and importantly, patient-reported outcome measures. Next slide, please. So, in addition, we really would like to advance electronic sources for data collection. So, and these are just some examples, including the ability for CMS to incentivize the use of interoperable electronic registries that could be used for multiple purposes, harmonizing measures across registries, and working on innovative approaches both for data collection for purposes of measurement, quality measurement and reporting, as well as quality improvement. Next slide, please. So in the area of transparency, this is both transparency, but also domains that really matter to those of you who do aging research. So the IMPACT Act was an authority that brought to CMS the expectation to standardize patient assessment data elements across post-acute care settings. And next slide, please. The expectation was to build quality measures based on these data elements. But what we did, and all of this information is located in the data element library. These data elements really are about function, mobility function, self-care, cognition, and also other important areas of function or consequences of function that we should be tracking across care settings, such as skin integrity, avoidance of pressure injury, and the like. And the thought is that the data could be used for care planning purposes, as well as being able to track over time and as people traverse the healthcare system. So the current gaps in the system of measurement currently are the acute hospital and also outpatient settings. But in the outpatient settings, we actually have alignment between the DEL and also some patient-reported outcomes through tools like the PROMIS tool. And so there is some commonality there. Next slide, please. So this just mentions some of the details, including what is of interest and is being measured as part of the IMPACT Act and is the basis for quality measurement and reporting for post-acute care, but can also be used for care planning purposes. Next slide, please. So, patients over paperwork. Some of you may have heard about this, and for us at CMS, it was a chance for us to really streamline some of our regulations and administrative requirements to lessen the administrative burden to permit clinicians and providers, healthcare providers, to focus on what they need to do, which is provide the best possible patient care, and also to unload the system so that we can improve not only the patient care experience, but also the provider care experience. So we had a number of work streams to reduce the paperwork that translated into hours and dollars of reduction from that administrative streamlining. This work is still underway, but I want to give you an idea of what this looks like. So next slide, please. So we use patient interview and human-centered design tools to understand the experience of care and the journey that our beneficiaries and healthcare providers actually have to go through to interface during the course of patient care, and also the administrative requirements that surround it. And that is what we look at to identify opportunities to streamline. Why this matters is because as you are creating the evidence It is not too soon to think about how is that evidence going to be used in in care delivery, and what does it mean? What kind of fidelity do you need in order to deliver and traverse that the outcomes delivered through patient care will be similar to what you observe in a scientific setting. So we believe that fidelity is important. So I will just show you a couple of slides here. Next slide, please. And some of what we learned. We studied the clinician experience. We studied the hospital, home health, dialysis facilities, and nursing homes, and also care transitions. What was it like for beneficiaries as they received care over time and space? Next slide, please. And so this, how do you choose your care? How do you actually, what is it like when you're paying your bills or receive those bills that are the consequence of the care that you have received? How do you actually keep this all straight? And, you know, these are all things that our beneficiaries have said to us. This is what is hard about receiving health care, right? How do we converse and know what goals of care are, and how do we maintain that over time as we interact with different healthcare providers? How do we navigate through the system, and how do we actually implement and have fidelity to the plans that we set with our primary care providers? So we're actually looking at all of this, trying to streamline the processes so that those who are providing care and receiving care can be very aligned and focused on translating the care goals over time. Next slide, please. And likewise, some of the challenges that we see manifest in a bunch of workarounds. So we learned that it is hard for people to get their prescribed oxygen, that it's hard for them to get their durable medical equipment. So sometimes what they do is for DMEs or for a walker, they may just go out and buy it, or a family member will go out and buy it and gift it, even though they're eligible for it. We find that care coordination or lack thereof has consequences, and that is some of the important work that you do about adverse drug events and avoiding all of that thereof, that it is not as simple as just a prescription written and therefore therapy ensues and all goes well. Many, many impediments. So we are looking at each point in this journey to see how can we improve that which we expect and that we pay for. Next slide. And the final one is, this was actually really important for us. This is the nursing home journey map. We studied nursing homes and interviewed staff to understand what was hard about their care. And some of these lessons that we learned in this journey are actually what we are seeing is what is not going well in the coronavirus pandemic. So some of these lessons learned are not just nice to have for administrative purposes, but we are applying some of what we learned to how can we help the system improve the care that's provided. Next slide, please. So I wanted to end there just to bring full circle that we are not only using the evidence that you all are developing in ways that support programs and policies that CMS has authority to initiate, implement, and also refine through various regulatory and statutory processes, but we actually have great interest in helping the field and helping care to evolve towards value-focused care, value defined by what is meaningful for the beneficiaries who we serve, but at the same time, mindful of the journey that our beneficiaries and clinicians are taking to really, and all the impediments that may arise, particularly those administrative impediments that we can streamline or remove so that care delivered actually more efficiently translates into better health outcomes. So with that, I will stop and really thank you for the opportunity to be with you and for your attention.
Dr. Ling, so much for that excellent talk and really nice overview of all of the work that CMS has done really over the past decade or more that this has been in the works, and it's wonderful to see. I'm going to ask our discussants to start us off with comments or questions. While we do that, also for participants, if you would like to type questions into the Q&A function, we will go through those questions afterwards. But our first discussant is Dr. Nathan Boucher.
Great, thank you. Thank you, Dr. Ling. That was fantastic. I really appreciated the overview of what CMS has done and is doing and planning for the future regarding new efforts and innovations. I'm really struck by the complexity of the CMS innovations in care and payment models. I would really love the American people to really understand that maybe there's new branding involved. I don't know, but it would be wonderful if patients and caregivers, families could really have a good handle on all the really great stuff being done. I think sometimes CMS is seen as sort of if they know about it at all as an entity, it's sort of a big monster, and that's just kind of an unknown. And so I'd really love I'd like to work with my patients and caregivers and so forth, and have them tell me, gee, CMS is doing some really innovative stuff. I think the public comment opportunities are a really nice opportunity for folks to get involved and have input. I do wonder if the people with the greatest lived experience applicable to some of your CMS efforts are actually being reached for this opportunity. And so I do sometimes call that into question. I think that the incorporation of human-centered design is fantastic. We're doing it in other areas. I'm really glad that CMS is doing it at such a big level to design and optimize the customer service experience and go beyond that. I think that's super. There's a really good diagnostic and therapeutic paradigm that CMS is doing. I'd like to learn more about what CMS is doing to consider more psychosocial aspects of care and what might be done by CMS to incentivize that type of care. And I love the advanced care planning that has now fallen under Medicare payment structure. I wonder how that's being formalized, or if it could be formalized in the Medicaid covered care and structure. And then lastly, I'm really excited to learn more about ways CMS is recognizing caregivers as part of the long-term care services and supports network. So I know that's a bunch of stuff, but I really appreciate that this sparked a lot in my own head. Thank you very much.
Terrific. Thank you for your comments. I want to say, and I'll just keep this brief because I know Barbara has other comments to make as well, but I don't want to miss the opportunity to say that we really value the perspective of the lived experience, and I will say that the products that we make, including our quality measures, look very different when we have people with lived experience as part of the technical expert panel. And we really have tried to integrate that into how we do business. And you're right, CMS is a very complex place with different authorities, and at times it's like living in the Winchester Mystery House, if anyone's ever been to San Jose. So we actually have the opportunity for people to come and do a fellowship, if you will, health and aging policy fellowship, or even residents and fellows who have, can stack together a few months. We welcome you to, come and learn. And we've also offered for our local regional training facilities and programs, we kind of do a CMS 101 just so that some of our geriatricians even, or surgeons who are in the area don't conclude their training without understanding at least how Medicare works or what is the claim. So really would be happy to follow up with you and try to sort through and see how can we bridge and demystify what it is that we do and how we work and what our programs represent. So thank you so much.
Thank you. Thank you for those comments. Barbara, I want to invite you to give comments or discussion as well, and I'll ask other panelists to maybe mute during the time that we hear comments from others. I think it will improve the sound quality a little bit.
Yes, thank you. And thank you so much, Dr. Ling. That was inspiring and somewhat frightening at the degree of size and complexity of CMS, and the fact that an organization so vast and so complex and so touching the deep part of people's lives really emphasizes both innovation and the inclusion of patient and family voices is wonderful, and for me personally, extremely hopeful. So thank you. And I have a couple of comments and a question that I wanna ask at the end. I heard, how deeply you listen to the at times really terrible and life-disrupting challenges that older adults and their families face when dealing with a health crisis, particularly around transitions of care. And I expect that I may wind up having some of those similar experiences, but I just wanted to share another side. I'm just a 2-year veteran of Medicare, and I have been delighted with the entirety of it, with the extent of access I have to my providers of choice, with the lower cost, and with the ease of the administrivia around the paperwork. Compared to what I used to have to do when I had private insurance, this is a cakewalk for me. And in particular, I deeply appreciate the peace of mind I have in knowing that I'm covered and that a catastrophe is not going to destroy me. One point I wanted to pick up on in your talk, and I want to underscore, and you in one of the slides, there was a point about the role of community-based organizations, in both health outcome and quality of life. So many of us have family and friends, and some of us don't. And most of us have connections or could possibly have connections with community-based organizations, whether that's, social service centers or community centers or religious groups. And we do know the great physical and cognitive and emotional toll social isolation takes on older adults. And of course, that's just magnified by the realities and the anxieties of this pandemic. So I would love to see CMS build even deeper partnerships and creatively fund these community-based organizations who have an impact, not just on creating social connections that are vital, but also addressing the social determinants of health, which we know account for 60 to 80% of health outcome. So here's a quick example I wanted to share. And this is in the spirit of innovation, that can lead to improved health outcomes for Medicare population. I'm on the board of an organization called San Francisco Village, which is not a place, it's an intentional community of older San Franciscans, 65 to 105. And we are currently engaged in piloting a partnership with a local hospital with their ACE unit, adult acute care for the elderly. They pay for a 3-month membership in San Francisco Village for discharged patients who are eligible and interested. So this is what that means. Within a day or two, these folks are connected with a volunteer who can pick up medication, drive them to follow-up appointments, get groceries, check in regularly, and most important, stick with them over time and build a trusting and ongoing relationship. So one woman, a pianist, was matched with a young violinist, and they made music together. A poet was matched with a poet, and for a while they wrote together. A 1960s activist was matched with a 2020 Black Lives Matter activist. You know, some people go for walks, garden together, watch movies, and these older adults can also join neighborhood circles and attend up to 30 different cultural and educational events a month. So now we've moved online, and volunteers are working with elders to help them Zoom and Instacart, and also use telehealth tools and My Health Online kind of tools. And so far, we've seen a reduction in emergency room use in this particular population, and in several instances, a reduction in 30-day readmissions. But from our perspective, you know, even more importantly, we're hearing stories about people finding lifetime friends and developing, you know, a deeper sense of meaning and connection beyond their apartment to a world that's greater than the world that they had before. So I wanted to share those comments, and I had a question. Louise Aronson, who wrote a wonderful book on elderhood, she's a geriatrician at UCSF, talks about older age in similar terms to the way we talk about childhood through young adulthood, that there are developmental phases and developmental milestones, and older age is very different for someone like me, you know, in their 60s than someone in their 70s, 80s, 90s, and beyond. And I'm just wondering, to what extent do you know of research that is following up on this concept of elder stages of development and looking at models of care that address needs and lead to improved health outcomes based on these older phases of development? Thank you very much.
Oh, gosh. Barbara, thank you so much for your comments, and indeed inspiring, as well as challenging. I think the concept of really what you're mentioning is, you know, the importance of that social bond, and to enable that as a part of living. I think the notion of meeting the beneficiary, the patient, the person, where they are in their life course is really, really important. It's an important context for how everything else is interpreted, and also perhaps the care needs and how they're delivered, what would they be willing to consider or not. So I think the concepts are really well aligned. I think what, and this is why alternative payment models and different care models actually are a better fit for holistic care, paying for holistic care than is fee-for-service. One of the challenges that Medicare has is by statute, there are statutorily defined things that can be covered. The management of a illness or an impaired body part. These are statutory words. And it's about, and this is also why dementia care is so hard, because it's not something you can touch, you can see. It is present. It's a filter. It is. It really can make the difference between success and failure, and yet you cannot physically see it. So I think this type of concept, what would be wonderful to be able to translate it into a model of care is if there were not just in the, well, it would be in the design, but what would quality care, how would you define quality of healthcare in this construct? And what would be the cost associated, but also the costs averted, and you really did refer to some of that. But you know, there's the scientific approach, and then there's translating that scientific approach into what CMS might have authority to address, which would be care and payment models that necessitate the inclusion of quality and cost in the construct. But the principles could align. It's just a matter of adding those elements to what you've described, and you have a defined population that you have already, you know, described. So something like that, I can see translating into, you know, potentially into a model of some type that could be just really mutually beneficial, you know, to all involved. And I could imagine, I was smiling as you were speaking because I was thinking that would be actually a really cool community to be practicing within, because it's about the holistic care of the person. So thank you for your comments and your thoughts. And I took a few, I take notes on my phone because I try to not use paper as much. But you did give me some really great nuggets to follow up on. And Nathan, also the question about advanced care planning and Medicaid and, you know, caregivers, that's also something, that's concepts that I will take back, because, you know, for us in Medicare and as caregivers are also our beneficiaries. And the consequences or the burden, and, you know, I am a long distance caregiver, and, you know, the consequences of that honor, that privilege of being a caregiver, has, you know, sometimes it's a trade-off. Well, do I go to get my follow-up checkup and things? I mean, there are things, you know, not sleeping as well because I'm worried. That added stress actually, it's a real thing. So how do we better take care of our caregivers, as well as be able to support them in the work that they do? So again, there's some things that CMS can actually provide payments for, and we took a big step in including caregiver assessment as part of the cognitive impairment billing code. We thought that was really important to require the assessment of how the caregiver is doing as an important step towards what you were asking about. But I did take some notes, and we'll bring that back. So thank you.
Thank you, Dr. Ling, and special thanks to our discussants. This is Leah Hanson. We do have some questions from the audience through our Q&A. And a reminder, please continue to submit those. Dr. Ling, the first question is more of a comment, but wondering if you could respond. So Orla Sheehan commented, when you listed gaps in meaningful measures, they would suggest adding measures appropriate for persons receiving home-based medical care. Can you comment on that?
Yeah, so thank you very much. And, you know, as we think about care provision, we, because CMS authorities are about paying providers, we tend to think about, you know, care that happens within bricks and mortar. But the principles would apply, and one start towards that is, you know, what we can pay for as a post-acute care service is in-home health. Now, that is not the same as home-based care. And one of the areas that we provide flexibility in the public health emergency is that care can be provided in the home, that we wanted to, by way of telehealth and by way of some of the flexibilities, enable, you know, house calls and home care. And I mean, we were mindful that, you know, we basically said, please don't come in for healthcare unless it's really, it really is needed at the time, because we're trying to manage risk with exposure. The challenge that we have is, how do we know you know, that what can we learn from how that was delivered? And so would love to hear back. You know, my email was on the last slide, I think, sherry.ling@cms.hhs.gov. If you have experience of how that actually is being delivered and what outcomes are resulting from that type of care, would really love to see it and to be able to receive it, and I will share it with our team because, you know, it's, we took the approach, let's take the fight to and provide the care at where the beneficiaries are. And that was, you know, that's in the home, and important proof of principle that it can be done. House calls as part of my training as a geriatrician, and really memorable and an honor and an important glimpse into who people are and how they are doing. So appreciate the comments. And should I be able to see the questions and answers? And if we don't get to questions, could you send them to me by email?
Yes.
I would really appreciate that.
Yeah, definitely. If you click on the box that has a kind of like a speaking bubble, that should pop up the Q&A. Those are the questions I'm reading from. So the next question we have is from Andrea Rink, and she asks, does Medicaid cover annual wellness visits and dementia screening?
So that's a good question, and it's something I should know the answer to, but I don't, because Medicaid, as you know, state authority will pay for necessary care and services, but that's something that I will find out, and it's actually another question that builds on what other care and services should we actually be aligning across Medicare and Medicaid. So the other question was about advanced care planning, but appreciate the question, and I'm sorry I don't know, or I'm sure it is provided, but I'm not sure where.
Okay, fair enough. Our next question is from Mary Schramke. She says, a great overview. Are there plans to improve and broaden patient and caregiver families' input to better understand the meaningful measures process? Specifically to educate them to better understand the measures and the process, and perhaps even test them in implementation?
Oh, great question. And yes, we intend to have the patient voice, the family voice, the person's voice as part of all of that work. And in fact, I have to think about this. We've actually built in language into many of our expectations for each and every program. So we will verify, but that is, I believe that is part of what we already have in place. So how do we let you know how to get engaged? What's the best vehicle to do that? Because we have many opportunities, either by way of technical expert panels or, that is, of course, you would always have opportunity to contribute public comments through the public comment process or the notice and comment process. But what is the best way to inform you all on this call? Because it does occur to me that you may not be scanning the the CMS websites or the usual places. So what's the best way for us to do that? Because it's a really great question, and I would love to be able to tap into the participants here and at least let you know if there are opportunities that are on the horizon.
Yeah, we'd be happy to connect with you. We have a quarterly newsletter that's emailed out to our group, and that might be a good way to seek input. Or we have a email listserv where we could send that out, but connecting with either Catherine or Chris, who helped you schedule this conference today, would be a good way. Any information you could send to them, they can distribute amongst our Aging Initiative members. That would be great.
Okay, that's wonderful. Thank you so much.
Okay, next question is from Marcel Salive, asking, what is CMS doing to improve accessibility to the vast resources, of Medicare claims data and other data that researchers might use?
So thank you for the question, Marcel. And we do have quite a wealth of data. We are releasing some public use files, including a tranche of data from up through, I think, early June for COVID. That includes, COVID data, hospital data, which is actually quite interesting. So we're releasing public use data files, but I gather from your question that there may be other aspects of accessibility to the data that would warrant us taking a look. So if, there are ideas on how we could enhance access to the Medicare data or the CMS data, because we've got Medicare data, certainly we've got the claims data, we've got all of the data that comes in through the required instruments, such as OAICs and MDS, so on and so forth. We also have the state data through TMSIS, and I cannot remember what that acronym stands for, but it is state data. We have some encounter data as well for the plans, but would love to hear from you if there's specific, what would enhance access in the way that you're hoping to see. And again, maybe you can just send that to me by email, sherry.ling@cms.hhs.gov. That would be fabulous.
Great. Our next question is from Chris Langston. Chris asks, as Dr. Boucher said, CMS has created exciting benefits such as advanced care plan, cognitive impairment care plan, annual wellness visit, and CCM. However, uptake of these has been very poor. What is CMS doing to modify the benefits or regulations or to get providers to use and deliver these?
Yeah, really great question. And this is one of the aspects we were looking at to try to understand why benefits that we build the uptake is not as we had hoped. And so part of this is what we are looking at through patients over paperwork. And when we actually look at some of the requirements, we can understand why there are, it's complex. Like it would probably benefit from simplification. So that's one point. Another is how we convey this information that these benefits or these codes are available for use and how to use them. Our usual route is to include the details in some of our Medicare Learning Matters documents and products, but that may actually not be where or how it actually would facilitate better uptake at the point of care or the actual users of these codes. would love to be able to understand what some of the impediments actually are. I will say that some of these codes, there's a lot in them. We try to be broad and flexible in how they're written, and sometimes, it runs the risk of needing greater clarity or follow-up because it's a little confusing of what we need or who they're applicable to. That type of feedback we would really value. So, Chris, thank you for the question. Because we would like the codes that we build to be used with the intent of improving the care that is delivered for our beneficiaries. So thank you.
Chris had a follow-up question about a specific program and asked, the Independence at Home demo seems to have gone quite well. Are there plans to create a permanent benefit?
Oh, yes, Chris, that I agree. It has gone well. I actually don't know what the plans are because that is a question that's under the Innovation Center Authority. But I will make a note of it and follow up with my CMMI colleagues. But point well taken. Very important work. Good outcomes, financials, right direction. So I will make a note to myself. But thank you for the reminder.
When we have a comment from Sherry Ling, who says, I've also been delighted with the response of Medicare for everything but medication copays. My meds are all tier 4 or 5, and last year I paid over $10,000 out of pocket for medication and prescribed supplements that Medicare did not cover. Mm-hmm. Could you comment on her comment if you'd like?
Yeah, so I see the chat now. Is it the same as the comments? Oh. Okay. So thank you for your comment. If you would, it's something that we have heard of before, and it is something that we're mindful of. So I would be glad to send that comment to my colleagues who are in the Center for Medicare, who actually are the ones who administrate the plan and the benefit, the drug benefit. So appreciate it. If you would like some follow-up, you can always email me, and I'll make sure your email gets to the right place.
Thank you. We have a follow-up comment from Mary Schramke stating, perhaps could you also engage QIOs to notify people of public comment on measures? They could also help translate measure background info, since it is often very technical and not very plain language.
Yeah, so thank you for the suggestion, and certainly when we are, the QIN QIOs, the Quality Improvement Network QIOs, have a very broad reach and do important work in engaging with healthcare providers across the country, even if they are, have their regional catchment areas. So I appreciate the suggestion. I will take that back as well. Thank you.
Sue Borson asks, can CMS work directly with healthcare systems to promote the uptake of these benefits, including the annual wellness visit, care plan, and CCM?
Yeah, hi, Sue. Thank you for the question. Some of that work happens through the QIN QIOs and other technical assistance. that we can provide. I think a first important step is really to understand, and maybe this is what you're alluding to, is understanding the why the uptake is low. And I know, especially if your interest also is encouraging cognitive assessment. I mean, it is a required portion of the annual wellness visit that, an annual wellness visit is one such vehicle that can happen through. So, the answer is yes, we can. I think the first important point is to understand why the uptake is not as we hope. So we can do that work by way of, receiving feedback, and any of you who are part of health systems, we would welcome any feedback you have from that perspective on either the annual wellness visit, the care planning, chronic care management, or any of the above. This is information we actually don't have eyes into, but it's important information if we are to improve uptake and to enable that the care and services that are covered then translate into what happens next, which ideally would be better outcomes. So thank you, Sue.
The next question is from Jessica French. Jessica asks, I wonder if CMS could use the same human-centered design approaches to working with clinical providers as it used with beneficiaries to ensure that policy translate effectively into practice.
Mm-hmm. Yes, and that's a really good point. And one of the slides actually, so there's two related concepts. So the human-centered design is about, for our project, we were looking specifically at what those administrative burdens were. And so we did interview clinicians, and, busy clinicians actually took time from their days to spend with us to really explain and for us to be able to observe what was hard about their work. And so, yes, absolutely. And it's actually the next one, a little bit further down. Sorry, hold on. So beneficiary nursing home, I don't know if I provided that to you. So this is the nursing home journey map. We did something similar for clinicians. And so the answer is yes, we looked at it from an administrative side, but there's also a workflow side that, you have to then also map out your workflow and ask the question, so how do we gain efficiency in how we do our work? At the same time as what we were looking at is what could we remove as far as administrative impediments and hurdles, so you can permit that work to happen. But still there is, I believe that it's synergistic, but both can be done, but you can start with a human-centered design type of approach. And I believe that some of those redesign questions are, you really do need the people who are in that environment to take part and to help with that redesign, because certainly CMS would be looking at the administrative part of it, but we actually wouldn't have as much awareness or knowledge of the actual nuances of how the work itself happens. So I think they're synergistic, but thank you for your question and suggestion.
Thank you. Those are all the questions I can see in the chat box in the Q&A. Heather or Chris or Catherine, do you see any additional questions that haven't been asked?
Yes.
Okay, I have one from Patricia Bomba. Excelis BCBS was the first health plan to pay trained providers for thoughtful ACP discussions for patients with serious illness. Barriers were that there was not enough time, it wasn't paid, and they weren't trained. They trained with communication skills and workflow improvement.
Hi, Pat.
Thank you, Patricia.
Hi, Pat. Thank you for the question. So I think, I think that is important work. The question is, what is it that CMS can pay for? And so this, again, there are some statutory requirements for who CMS can provide payment to directly. And so perhaps that's one of the limiting factors there. However, we do know that, some care models and systems, and you're right, that some of the plans have greater flexibility about what could and who could be paid for what type of services. They would at least have to pay for and cover that which fee-for-service Medicare pays if they're Medicare health plan, but they actually could go beyond and have more flexibility as with Medicaid. So perhaps that is a step in the right direction. Otherwise, I'm certain that that type of service and that type of communication could be very, very meaningful and important part of some of the future care models with a better chance of hitting a target of improved outcomes that are meaningful. So I'm sure you have already engaged with some of my colleagues in the Innovation Center, but if not, would be glad to convey that. And Pat, I think you sent me an email about something like this before. If you don't mind just refreshing that, and I will get that to the right place. Thank you so much, Pat.
We have a question from the discussant, Barbara Kivowitz. She asks, what are some of the conversations you and your colleagues are having as you consider the current and potential ongoing impact of the pandemic and the short-term vaccine immunity on CMS beneficiaries?
So we have been crazy busy, really, using CMS authorities to help to really solve problems that have arisen as a consequence of the SARS-CoV pandemic. So COVID-19 is really hitting our beneficiaries hard, both those who reside in nursing homes and, in close proximity, other congregate living situations, and those who actually even are living in the community but doing their best to stay out of harm's way, and as a consequence may not be coming in to receive the care that they need, or no doubt are suffering from the isolation that it's recommended, social distancing and transmission breaks precautions, and that translates for many into social isolation. So, we have been really looking at and using every authority that we have, every flexibility that we could conceive of, and that we have authority to utilize to ensure that we can provide access to the needed care and services, and that the healthcare providers in health systems across the country have the flexibilities to provide the care and services that are really what our beneficiaries need, so that's what we have been doing. We have also been pertinent to the earlier discussion about data, trying to make our data available for the public use so that we can learn together about what the impacts are of this pandemic, and in long-term care have, together with our CDC colleagues, stood up a national reporting system so that we have tracking of events that affect our residents and also healthcare workers, and the impacts on the facilities, which have been really, really astounding, but importantly also track to that which we need to effectively fight this pandemic, which includes supplies of personal protective equipment and testing supplies. Those two are being tracked. So we've been at work in a variety of ways, both enabling flexibilities and approving waivers, as well as helping to stand up data reporting systems that we really did not have prior to the pandemic, and that data is also being made available for public use. So we recognize, and we are hopeful that we will be, with all that we've done, that we will be better prepared, and that we can learn our way through this together. So I really appreciate your question. So thank you.
Well, and a big thanks to you and your colleagues for working so hard to address this unprecedented pandemic. We have reached the end of our time together, and wanted to extend another thank you, Dr. Ling, for an excellent presentation and such a stimulating conversation. Big thanks to our discussants, Dr. Boucher and Barbara Kiewicz. Thanks for our audience for all of your great questions. The recording for the webinar will be posted soon on the Aging Initiative website. As you sign off, you'll be prompted to complete a very brief survey regarding any thoughts or opinions you had about today's webinar. We'd really appreciate your feedback. Thanks to everyone, and have a great rest of your day.
Thank you.
Bye.